Welcome back to the third section of this panel discussion. You've heard a general review of highlights of the recent ATS meeting, and you've heard brief summaries of three really pivotal trials, clinical trials in the field of idiopathic pulmonary fibrosis. So now we're going to have a panel discussion about those trials, discussing some of the nuances and issues raised by them, and then talking about the clinical implications and the implications of these trials for future clinical research. So Luca, can you give us just an overview of your takeaway from the three trials?
My first takeaway that it has been an historical ATS conference for IPF, because 3 phase 3 trials, all published in the New England Journal of Medicine, presented at ATS conference, I think is something that we were not even able to dream of a few years ago. So that would be my major take home. I think that we, as a community, we did a great job showing that in a disease difficult and rare like IPF, it's feasible to test drugs in the proper way of placebo-controlled trials. That would be my first take home. And then the second is that it's possible to show reduction of disease progression in these patients with the 52-week trials. And that's also very comforting for both patients, physicians, for future drug development. And I think that the take-home message that I will be taking back home with me, apart from the emotion of seeing this room full of colleagues waiting for these results, and it's just that we are probably opening a new era in the treatment of this disease.
Great, thanks Luca. Sonye?
I would really echo Luca's sentiments that this was a momentous step forward in terms of identifying new promising agents for the treatment of idiopathic pulmonary fibrosis. And I think that it really spoke to the fact that the world community can come together to conduct very high-level clinical trials, and that there really is a global effort to find a cure for this disease. I think that it also points out to us that this is really not the end of the quest, but the beginning of it. These were hopeful agents that have slowed the rate of progression and have had some clear benefits in terms of mortality and exacerbations, but they still haven't shown the universal benefits in terms of patient-reported outcomes that we would hope that these compounds might also show in clinical trial. So I think that it's a really important start, and I think that it really shows that we can do this as a community, and I hope that it's the beginning of things to come for our patients with IPF.
Great, I'm glad you mentioned some of the different endpoints and either the benefit or lack of benefit. We'll come back to some of those issues in a while and talk about them. Dave?
Well, I certainly agree completely with what Luca and Sonye have said. For me, in the U.S. at least, having nothing, for years, and now having the potential for 2 effective treatments is really exciting. And of course, I think you can draw a number of conclusions from that. One is that obviously our patients are, this is a whole new world for our patients. And, but on the other hand, on the drug development side, this means that it can be done. I think for many years there was some pessimism that maybe we can't do this, maybe this is not really feasible or possible. It clearly is. And so I really hope that this monumentous week and these 2 great publications really start to stimulate both NIH and the pharmaceutical industry to really push on drug development some more.
Great. Vincent?
I certainly agree. I think this is really a landmark for IPF. We've learned results of 3 major trials. One showing that the drug N-acetylcysteine that we've been using, especially in Europe for a number of years, doesn't seem to have any clinical benefit. Second, we've seen that pirfenidone that we have been using for over a year in several European countries is demonstrating a real benefit. So it's increasing the level of confidence we have in the drug and the treatment benefit that we can expect from the drug. We'll talk about survival. And then we see a third trial that is showing that we will very soon have another drug for IPF. So really, I think this will change the landscape for IPF, for patients, of course, because they will have access to one and even two drugs. For physicians, because we will see, hopefully, the disease slow down in progression and translate, these benefits will translate into the routine follow-up of patients, and that will also change the research.
Great. So I think it's fair to say we have consensus among the group that this was truly a momentous occasion for IPF. Maybe just a couple of general comments before we dive into the details of the trials about what these trials have told us about the natural history of disease, and does it make you think about it a little bit differently, or are there important considerations that maybe in trial design that have affected what we're seeing? Vincent, maybe we'll go backwards here and we'll start with you. Do you have anything to kind of comment about that?
Well, I think the low rate of mortality and the low rate of exacerbations that we see in these trials is mostly due to the fact that we are looking at the population with mild to moderate disease. And this population is specifically selected for participating to trials with the objective of meeting the primary endpoint and measuring FVC. And we know these trials are not powered for studying mortality. So we are looking at specific population, which is representative of the overall population of IPF patients, but on the spectrum of disease early on. So we are not expecting a high rate of mortality. And mortality and acute exacerbations, we see them in the routine follow-up of patients in the community, in academic centers. So we know this high mortality of a median survival of about 3 years is unfortunately the true mortality of the disease.
Vincent, I think you really just described the explanation really well. If you think about the patients in your practice who have an FVC in the range as in the 60s or in the 80s for the different trials, and DLCO in the 40s, on the average, maybe that's not an unexpected mortality and acute exacerbation rate of what we observed in these trials. I completely agree. A second factor is probably not quite as important as the disease severity factor. The second factor is true for all clinical trials, which is that anyone enrolls in a clinical trial is selected to be a good candidate to be in the trial. So these are people who are more likely to be compliant with therapy, don't have a lot of comorbidities. And of course there's a upper limit of age for many of these trials, at least for, I don't know if it was true for both, but so I think that there are a number of factors that probably play in there as well.
Yep. Luca, did you want to add a comment about this?
Yes, I think that we have been learning from this trial, and we'll be learning from this trial. And one of the lessons that we are learning is that in terms of the rate of acute exacerbation, we detected the rate of acute exacerbation relatively low, below 10% as a maximum rate. And even more interesting, maybe, when we adjudicated those acute exacerbations, 50% have been adjudicated as non-acute exacerbations. So maybe we might be ready for future trials to use different criteria to define acute exacerbations. Or we should realize that when we are talking about diseases that are so rare in this range, it's difficult to show effects of sizable effects.
I think as we've talked about before, particularly in this population, and I can't remember which of you brought this up, but it may be that in a more advanced or severe population that endpoint would be easier. Sure. But I think it's a good point you make that it's difficult, given all of the issues around identification and the selection of these patients, as both of you have mentioned, them being so healthy, to get much signal from that endpoint, perhaps. Sonye, speaking of endpoints, I wanted to come back to something you mentioned before, which is the issue of quality of life or symptom measurement. And I think you brought this up in your initial comments, but we've wonderfully been able to show impacts on measures of disease progression and even in combined data sets on survival, but we've had a really hard time, in fact, if not basically not been successful in showing differences, not even improvement, but differences in quality of life or symptoms.
Well, I think it's actually a pretty significant conundrum that as a community we need to think about. We have traditionally powered our studies to something that is a disease-centric metric, that is lung volume, as well as mortality. And I think that we've had a less precise understanding about how these issues impact patient quality of life, and for that matter, patient symptoms. I think that there's really an emerging area that needs to be explored to try to understand how we optimize both physiologic measures as well as patient-reported outcomes. And it's entirely possible that we're going to find that some of the interventions that we make may benefit the physiologic measures and may, in fact, be detrimental to the quality of life metrics. And certainly when we talk about a number of the studies that we've had recently and the recent studies, there are fairly significant side effect burdens that come along with these medications. So I think moving forward, we just need to be mindful that the change in FVC, while being part of what we need to measure, is only one piece of it, and that we need to continue to think about how the patient-reported outcomes, how patient symptoms are integrated with these more concrete measures that we've powered our trials to ascertain. Yeah. And it may well be that that much like some of the other endpoints, we simply don't have the power to detect some of the changes in patient-centered outcomes that we need to and that we should be measuring.
Do you think it's reasonable to expect that we would see improvement in quality of life with drugs targeting, let's say, fibroproliferation or the disease process itself?
So the first issue is that I do think that if you have a drug that slows progression of the disease, that you will end up with a beneficial impact on disease, on symptoms, on dyspnea or functional status and other things. The problem here is, number one, of course, we don't think that you're going to improve quality of life, but you may detect the difference at the end of the study, just like you detect the difference in FVC. That can be hard to do because, on average, you may still expect both groups to get worse over time, just like we see with FVC in the active and placebo arms of these trials. The other thing is that based on the percentage of patients who are actually getting worse during the course of a study, you may have only a few people where you're having a significant impact on symptoms at 52 weeks, but if you were to follow these people and if you were to keep people on drug for a year and a half or 2 years, those early changes in disease progression may translate into large benefits later on. We don't know. It's kind of a black box for us right now. The other issue, which relates very much to measurement of many patient-related outcomes in IPF, is that we kind of lack a standardized disease management plan for patients with IPF. We have great guidelines on what to do, but we don't have great details that we all agree on and how to do things. And there's a lot of center variability in terms of how aggressively we use oxygen and pulmonary rehab. I mean, my oxygen prescriptions are very detailed, and there's a lot of home oxygen monitoring with pulse oximetry, and I think that improves dyspnea. So if you have patients who are progressing and using more oxygen, they may not have a lot more dyspnea immediately, right, because they're using oxygen appropriately. So a lot of these different issues intersect, and I think just make it really hard to detect differences in patient-related outcomes such as dyspnea and quality of life. But it doesn't mean that we should stop. It just means that we should keep working at it.
Yeah, they're multifactorial and maybe just a more challenging endpoint to hit. Yeah. It seems around quality of life and symptoms that maybe we have reasonable metrics. We may need to make some refinement, but that the issue may be more the complexity of the endpoint, the lack of power, perhaps due to the lack of responsiveness of it, perhaps lack of time, as you mentioned, to kind of see an effect. I guess my question is, do you think that for people interested in quality of life or symptoms as endpoints, we should focus more on kind of study design issues, duration, size, controlling for potential co-contributors to change in that endpoint like oxygen? Or do you think we need to focus more on getting a better tool? Is that question clear to you? Which direction would you suggest we go?
I think we should first improve the tools we have, because measuring quality of life is extremely difficult, and like you said, it's multidimensional. And I would probably target more the measurement of the symptoms. And I think measuring dyspnea is difficult, but probably cough is more accessible as an endpoint, because there are tools available that we don't use yet to measure cough in these trials. And although not all the patients with IPF do have cough, some who do, that's really impacting their quality of life. So we should probably work on that and maybe do specific studies for symptoms and improve the tools we have for measuring these symptoms.
And it sounds like you're saying also narrow a little bit our look, instead of looking maybe broadly at a quality of life, look at a specific symptom that you think is your disease.
Exactly. I don't think there is a
impact.
possible tool that can measure quality of life the same for every individual around the world.
I completely agree with the view of my colleagues, of course. I think there are two points that I will add to your. One, we should not forget that at least in a 52-week trial, we will have an imbalance in side effects in the treatment arm. So, by definition, those side effects will decrease the quality of life. And so, we will need to probably develop specific tools that are not too much influenced by those side effects in order to get a more clear signal. And the second point that I would like to make is that we probably need to get more patients involved in the design of the tool for measuring quality of life. I mean, we have a fantastic advocacy group across the world. And I'm sure that by involving patients in the design of specific quality of life tools, we may have a better signal that in the end will be more easy to understand and more easy to translate to something clinically meaningful.
Yeah. I want to shift to just a couple of questions around the other two trials and start with the question of the patient characteristics or the cohort characteristics. So, and the question is really, how do you think about the patients that were enrolled in the ASCEND and INPULSIS trials? Were they more or less similar? Were there important differences? And I'm thinking here with, in the context of the different inclusion and exclusion criteria. So maybe Vincent, you can speak to this first. I mean, do you think the results of these two trials are speaking to the same patient, or are there important differences?
Well, the population selected was pretty close. Then if you go into the detail, you can find some differences. The ASCEND trial made really a point of excluding patients with associated emphysema, and refined slightly the inclusion criteria as compared to the preceding capacity trial. One of the inclusion criteria was that the patient had to have an FEV1-FVC ratio above 0.8, which is quite high, but we know that in IPF patients in general, this ratio is around 0.9 when there is no emphysema at all. So by doing that, you really avoid to have some noise, and you restrict to the patients with pure IPF. And another way this was done was also to have the committee to review during the selection, the screening procedure, a central review of the chest CT, of the lung biopsy when available. So that really made the study very strong to select patients with definite IPF. And in fact, 95% of the included patients had a definite pattern of UIP on the chest CT, which is something that has not been seen before in an IPF trial.
Right, in the ASCEND study, yes.
In the ASCEND study,
right.
Yes. And in the INPULSIS study, but probably Luca will talk about this more, the imaging criteria was slightly different. So there is a broader inclusion regarding imaging, but the functional criteria were close, and we end up with a population with slightly higher FVC at baseline as compared to the ASCEND trial. But overall, the populations are, in both trials, IPF patients with mild to moderate disease and FVC above 50% of predicted.
So let's talk about that imaging difference, and maybe I can jump to you, Luca, just to explain a little bit, because I think you've hit on an important difference, which is in the ASCEND trial, almost everybody had a UIP CT appearance.
With honeycombing.
So meaning with
In most of
honeycombing,
them, yeah.
correct. And in the INPULSIS trials, the inclusion criteria were quite different. Can you explain that, and then maybe also give us your sense of
Yes.
how important that might have been?
I think it might have an impact. Any study population of any clinical trial is not clearly comprising the whole spectrum of the disease. That's by definition. You have inclusion and exclusion criteria. So in terms of overlapping of these two populations, what I can tell you is that the inclusion high resolution CT scan criteria for inclusion were basically taking the presence of traction bronchiectasis as an equivalent to the presence of honeycombing in the right context. So in patients in which there were nothing against the diagnosis of UIP on the CT scan, if they had traction bronchiectasis or honeycombing, were allowed to enter the trial. And as a result, about 1/3 of the patients had non-honeycombing traction bronchiectasis. And so there are subgroup analyses ongoing, and this is why trials are so important. And apparently there are no real difference between these two groups in terms of disease progression and response to treatment. So what I get from here is that it's impossible to get two really overlapping populations in clinical trials. They're compared. Even the racial background was different, because the INPULSIS trial, they get 30% of Asian patients that were not present in the ASCEND. In terms, is this translating into the way we diagnose disease or the way we are going to use this drug? I don't think it's. I think I would like to agree with the comment of Vincent that in any case we are talking about patients with IPF. And in each case we know that disease progression is there. So I think these are subtle differences that may be useful to interpret the data that we have seen in the trials. But the idea that we'll be enrolling exactly the same patient population in two different trials, it's relatively impossible.
So let me see if did you have a comment you wanted to make?
I just wanted to make one quick comment about that, which is, I think that you've brought up a really important part of the thinking about making the transition from clinical trial to clinical practice, which is that every patient who was presented for evaluation for the trials was thought to have IPF. And then based on the exclusion criteria, many of the patients who were referred by their local physicians were taken out of the pool that was then tested. And I think that when we then go back with drugs into the community, with therapeutic agents into the community, we're then once again giving those medications to everybody who was originally thought to have a compatible diagnosis. And in some senses, I think that the very narrow inclusion criteria is somewhat to the disadvantage of our understanding of how it will actually impact when it's brought out into the larger community. And so I think that the broader inclusion criteria may again reflect a slightly more general population. Specifically, the exclusion of patients who had, from ASCEND, who had the FEV1 to FVC ratio that was less than 0.8, clearly is going to impact a fairly large percentage of the patients that we encounter in a clinical situation. And again, it just makes it somewhat harder to understand how you can take those clinical trial results and apply them when you're actually treating patients in your community.
Yeah, so let me pick up on that and ask Dave a question, but first just summarize what I think we've said here about the patient populations. If I hear you right, I think your view is that while there were important differences in inclusion-exclusion criteria, maybe the most prominent or being the CT criteria, that in the end the feeling is both trials captured patients with IPF, and that they're more or less we're looking at the same disease. We're speaking to the same patient with these results. Yes, there may be implications for labeling or indications down the road with approvals, but scientifically speaking, we feel that the patients are more similar than different. Is that fair summary of what you said?
Yes.
Okay, but Sonye, I think your point is a key one, which is how first, how can this play into eventual clinical use, and also the question then of off-label use or use, let's say, outside of the study population. And so I think my question to you, Dave, is to maybe help us think about that a little bit, because clearly patients and physicians will feel pressured and feel like there would be value in using these drugs, assuming they're approved, one of which, of course, is already approved for two of you, in patients who, at least in some patients, who don't meet the inclusion criteria for the studies. Can you give us your perspective on that difficult situation?
Yeah, so there are a number of aspects to that. I'm not going to talk about whether or not the drug ought to be used for people without idiopathic pulmonary fibrosis who have other fibrotic lung diseases. That's a whole other discussion. But for patients who do have idiopathic pulmonary fibrosis who happen to not exactly meet the criteria for one or the other study, would it be appropriate to use drug to treat them? I think in some cases the answer is going to be yes. People who, for example, have an FEV1 to FVC ratio that is, say, 0.75, would you consider pirfenidone for them? I think, sure, you would. I don't think there's a real reason to expect that the drug's not going to work for them. They may have a lower risk of progression. The magnitude of benefit might be smaller, we don't know. But it would make sense to consider them, at least, on an individual basis. The other big question, though, is what do we do for people with an FVC under 50% predicted? So I'm not aware of any biological or mechanistic reason that one drug or the other would not work for patients with more severe disease. And if the relative risk reduction that we've seen for both of these drugs applies to those more severe patients who are at higher risk of progression and higher risk of death, they would have a much bigger absolute benefit or absolute reduction in risk with these drugs. So you stand to have a really strong impact on those with more severe disease. We do have a lot of questions about tolerability, and I do think there's lots of room for future investigation there.
Yeah, that seems like a key message, which is it seems like a very promising area to look at, and we should do that. So this has been a great discussion. I think we've talked through a lot of the issues around these three trials. I think we've agreed that of the three, the acetylcysteine trial is a negative trial, and while we'd like more information there, it's kind of unclear that there's a real role for acetylcysteine, at least new acetylcysteine, in this disease. The pirfenidone and nintedanib results, however, are different. And I guess my last kind of question to you as a panel is around, I know an issue a lot of our listeners, I'm sure, are thinking and hoping we'll get to, which is comparability. So I want to ask each of you if you'll just comment on your views of what we can and can't say about kind of comparability of these drugs. And if we can't, what additional information do we need? What additional studies do we need to do? And how do you think about the kind of relative efficacy of these drugs? So, Vincent, maybe I'll start with you.
Well, I'll keep it simple then. I think we should refrain from directly comparing the studies because we are looking at slightly different populations. We are looking at drugs with different mechanism of action, and especially we are looking at different endpoints, and I'm sure we will discuss that more. So we are not in a position to directly compare that. So we need to work on which drug to use when, and trying to predict in the future which patient may benefit the most of one or the other. But at the moment, we should not just compare numbers. I think it would be wrong.
Dave?
Yeah, I completely agree. I'm not going to say very much because I completely agree, Vincent. I would say it is very difficult to make quantitative judgments about magnitude of effect when comparing cross studies for the same reasons that Vincent said. Even the differences in different endpoints, I think, are hard to compare. And you would, obviously, what you need is a head-to-head trial. Whether that will happen, who knows? So I think in the end, maybe the decision to use one drug or the other is going to boil down to factors other than efficacy measures and probably individual discussions with patients about tolerability, things like that.
Sonye, do you think maybe there are, getting back at this issue I think we brought up earlier of personalized or precision medicine, do you think maybe there are different populations that would benefit differentially from this, or if we can't tell from the data, is that something you think we should?
Right. Well, I think that's actually going to be a key part in the coming months and years, is going to actually be post hoc analysis of the patient populations and trying to use in the studies in which biomarkers were collected and samples were collected for genetics to try to better pinpoint which subpopulations benefit from each of the treatments. And again, I think that there's very good reason to think that you might be able to stratify patients who are at higher risk for acute exacerbation or higher risk for progression. And for those patients, it may be that one or the other drug is preferable. But again, I think we're at the beginning of understanding this rather than at the end of understanding it.
Yeah, and it's a good point. I mean, even going forward, post-approval studies, for example, could still look at the issue you're bringing up if they collect biological samples and can try to look for responders. I think that's a great suggestion. Luca, as a final comment, maybe you could address the initial kind of question about comparability, but also can you speak to your thoughts on combination therapy?
Right. So comparability, I agree completely with my colleagues that it's virtually impossible to compare to different clinical trials, and it might become misleading to a certain extent. So I will mention few of the differences that might account for not being able to compare. We discussed about inclusion criteria, but choice of endpoint was another one. So we're talking about lung function, but the way lung function was measured was the imputation of missing data, the management of how to calculate the rate of decline in each single patient. These are all differences. And there are differences because we don't know which is the best methodology to do that. So given this level of uncertainty, the only certainty we can have is inside the single trial. When you randomize and you get a placebo-controlled trial, then you believe what you see. When you go to the external comparison, I think all of that will become really speculation, which is useless in the best scenario. In terms of combination treatment, this is an issue which is obviously apparent and evident, because I'd say you have two drugs that slow disease progression. Why don't you think that combining these two drugs may actually be of benefit of these patients? I think we need to be very cautious about this, very. Because first you need to have a biological rationale for combining drugs. They have to be at least non-antagonist in terms of per side effect, but also in terms of pharmacokinetics, pharmacodynamics. And in theory, they should be synergistic in terms of mechanism of action. This is something that we don't know. Secondly, it's possible, as mentioned by you before, that we have, as in any drug, subgroup of patients which will respond to one drug. And for this drug, it would make sense to use the drug in that group of patients. The combination will become a little bit of a danger to the patient. We have to think about safety first. So, as any drug, safety comes first. And we don't know at the moment if combining these two drugs might actually result in increased level of side effects and potentially severe side effects. Last point that I'm mentioning because I moved to the UK since a few months ago is cost. Not necessarily adding the cost of a drug, the cost of another drug is becoming cost effective in the end. So all of this is something that, just to say, to answer your question, this is what I think at the moment. Are we going to design, or are we going to try to answer some of these questions and to move this forward, and maybe to look in the future if this might be a possibility? Hopefully, yes.
Thank you, Luca. So with that, we'll stop and summarize. I first want to thank the panelists for their participation. I think this was incredibly helpful and insightful, certainly for me, and I hope for you watching at home. It sounds like we all agree this was a momentous session and meeting for idiopathic pulmonary fibrosis and for interstitial lung disease in general, but that we still have a long way to go. That the clinical use and implications of these results are still being worked out, and hopefully with thoughtful clinical research going forward in the next years to come, we'll have more answers for you about how to take this exciting news into practice.